Welcome, curious minds, to the deep dive. Today, we're embarking on an extraordinary journey into the very heart of cardiovascular complexity. Imagine your heart as this magnificent four-chambered mansion, right?
Right.
And its valves are like these perfectly synchronized one-way doors controlling the flow of life. Now, what happens when just one of these doors malfunctions? That's already a significant challenge.
Definitely.
But here's where it gets truly fascinating. What if multiple doors are sticking, leaking, or maybe even both, all at the same time?
Yeah, that's when the intricacy just skyrockets. We're not just looking at a single broken hinge. We're dissecting a symphony of complex malfunction.
Exactly, and getting a master's understanding of how to approach fixing it.
Indeed. It's like a cascade effect,
Yeah.
where issues in one part of the system can profoundly mask or exacerbate problems elsewhere. It creates this diagnostic and therapeutic puzzle that honestly challenges even the most seasoned clinicians.
So our mission for you, the listener, in this deep dive is to kind of transcend a basic understanding and really achieve what we call an elite professional level of insight into multiple and mixed valvular heart disease.
That's the goal. We aim to equip you with the nuanced knowledge, the stuff that differentiates true mastery in this field.
Absolutely. We're setting out to truly master the intricacies of diagnosis, the often deceptive pathophysiology, and the cutting-edge treatment strategies when these heart valves don't act in isolation, but rather in this complex, interwoven dance, sometimes working together, sometimes against each other.
Concert or discord, yeah.
To guide us, we've distilled the very best insights from expert sources, transforming them into actionable knowledge that you can immediately integrate into your understanding. So let's begin by unpacking this fascinating field. Maybe start with a valve that often receives a bit less attention, the pulmonic valve.
That's an excellent starting point, actually. Understanding pulmonic valve disease often gives us a clear initial picture of isolated valve dysfunction before we layer on the profound complexity of multi-valve scenarios. Let's delve into pulmonic regurgitation, or PR, first.
Okay, so just to start simply, what exactly is pulmonic regurgitation and, what causes it?
Okay, so pulmonic regurgitation, PR, is basically a condition where blood leaks backward. It goes back into the right ventricle, the RV, from the pulmonary artery, the PA, during diastole.
Diastole being the relaxation phase when the heart fills.
Exactly, the filling phase. What's particularly interesting about PR is the variety of its origins. It can stem from primary valve pathology, meaning a direct intrinsic issue with the pulmonic valve leaflets themselves.
Like what kind of issues?
Well, think of conditions like carcinoid heart disease. That's where circulating hormones can cause this fibrous thickening of the valve. Or infective endocarditis, an infection on the heart's inner lining and valves, which can lead to direct damage.
And it's not always the valve leaflets themselves causing the leak, is it? I seem to remember the ring around the valve, the annulus, can also be involved.
Precisely. You're hitting on a crucial point there. The pulmonic valve annulus, that fibrous ring supporting the leaflets, can dilate, it can widen.
Ah,
And this annular enlargement is actually a common cause of PR. It's particularly prevalent after surgical interventions, often done in childhood, to repair right ventricular outflow tract, or RVOT, obstruction.
like tetralogy of Fallot repairs.
That's a classic example, yes.
Yeah.
Repair of tetralogy of Fallot, or maybe following percutaneous pulmonic balloon valvotomy, which is a procedure to open a narrowed pulmonic valve. In these cases, the structure, the integrity of the valve or its surrounding support, has been altered. That predisposes it to leakage.
Makes sense.
And furthermore, long-standing severe pulmonary artery hypertension, really regardless of its underlying cause, can also lead to significant dilution of the pulmonic valve ring. That, in turn, causes or worsens PR. It's a key mechanism of what we call functional PR.
So functional, meaning the valve structure itself is okay, but the surrounding changes cause the leak.
Exactly. The leaflets might be fine, but the dilated ring prevents them from closing properly.
Okay. So once PR sets in, especially if it's severe, how does it fundamentally mess with the heart's mechanics? Can you walk us through the pathophysiology?
Sure. If we connect this to the bigger picture of cardiac function, severe PR imposes a really significant burden on the right ventricle. It leads to RV chamber enlargement and a specific type of muscle thickening called eccentric hypertrophy.
Eccentric, different from concentric hypertrophy.
Yes, very different. Eccentric hypertrophy means the heart muscle thickens, but crucially, the chamber also dilates. It stretches out to accommodate that increased volume coming back. It's the RV trying to adapt, but it's a costly adaptation long term.
Okay.
PR essentially creates this dual stress, a state of both increased preload and increased afterload.
Could you quickly break down those two terms for us again? They're so fundamental in cardiology.
Absolutely. Think of preload as the volume of blood stretching the ventricle at the very end of diastole, right before it contracts. With severe PR, blood is leaking back into the RV, so there's just a larger volume of blood stretching the RV. That means increased preload.
Got it. More stretch.
Right. Afterload, on the other hand, is the resistance the ventricle has to pump against to eject blood out. In PR, the RV has to pump against the pulmonary artery pressure, which might already be high, while also dealing with this regurgitant volume that's flowed backward.
So it's pushing against pressure and dealing with a reverse flood?
Exactly. That double burden is what makes severe PR so demanding on the RV. It's getting hit from both sides, essentially.
And that explains the characteristic sound a doctor might hear, doesn't it? That decrescendo diastolic murmur. How does that specific sound happen?
It absolutely does. The unique decrescendo or progressively diminishing nature of that diastolic murmur in PR is a direct result of the pressure gradient changing. Well, as diastole proceeds, the pressure difference between the pulmonary artery and the right ventricle gets smaller and smaller. The RV is filling, so its pressure is rising, while the PA pressure is falling after systole. This shrinking pressure difference across the leaky valve is what generates that fading murmur sound.
Oh, okay.
And what's also a really critical clinical clue is that if the right ventricular diastolic pressure increases, meaning the RV is becoming stiffer or more overloaded, it'll actually shorten the duration of that murmur.
So a shorter murmur could actually mean things are worse.
Counterintuitively, yes. A brief murmur in the setting of known severe PR can be a sign of very high RV and diastolic pressure, indicating significant compromise. It means the pressure equalizes faster.
Fascinating. And how does all this affect the heart's overall pumping ability, the cardiac output?
Initially, the forward cardiac output, meaning the amount of blood the heart effectively pumps forward to the lungs and then the body, is often preserved. The RV has this remarkable capacity to adapt, at least for a time.
But not forever.
No. As the disease progresses and the RV keeps struggling with this chronic volume and pressure overload, its ability to increase cardiac output normally, say during exercise, diminishes. And eventually, even the resting cardiac output will start to decline.
Are there early warning signs of that decline?
Yes, a crucial and often early indicator of hemodynamic compromise, meaning the heart's pumping is starting to be significantly affected, is a reduction in the right ventricular ejection fraction, or RVEF. That's a measure of how much blood the RV pumps out with each beat. Seeing that number drop is a red flag.
Okay.
In the really advanced stages of severe PR, you'll see substantial enlargement of both the right ventricle and the right atrium, the chamber that collects blood before the RV. This is often accompanied by a marked elevation of the jugular venous pressure. You can actually see the neck veins pulsating, reflecting severe right-sided heart strain and congestion.
So how does someone with PR typically present? What symptoms would they experience, and what might a doctor find on physical examination?
In terms of symptoms, mild to moderate degrees of PR are frequently asymptomatic. Patients might not even know they have it. If symptoms are present in these earlier stages, they're often kind of overshadowed by other underlying conditions, particularly pulmonary artery hypertension, which might be the main driver of their discomfort anyway.
But as it gets worse.
Right. As PR becomes progressively severe and right ventricular dysfunction develops, patients commonly report fatigue, exertional dyspnea, that's shortness of breath with activity, and then symptoms of systemic venous congestion. Things like abdominal fullness or bloating because the liver gets congested, and lower extremity swelling or edema. These are direct signs the right side of the heart is struggling, leading to fluid backup.
And on physical exam, is there that classic finding? I've heard of the Graham-Steele murmur.
That's indeed the hallmark, the Graham-Steele murmur. It's described as a high-pitched, decrescendo diastolic murmur heard along the left sternal border. Now, this murmur can be quite tricky to distinguish from the more commonly encountered murmur of aortic regurgitation.
Because they sound similar.
A very similar sound, but AR originates from the left side. What helps differentiate the Graham-Steele murmur is its potential to become lighter with inspiration. That's a characteristic of right-sided heart murmurs. More blood returning to the right heart during inspiration makes the murmur louder.
Okay, that's a useful clue.
It's typically associated with a loud and sometimes even palpable P2. P2 is the pulmonic component of the second heart sound, and a loud P2 usually points towards significant pulmonary artery hypertension. An RV lift, where you can see or feel the right ventricle pushing against the chest wall, is also often present, consistent with an overloaded or hypertrophied RV.
And you mentioned this murmur is particularly relevant for certain patient groups.
Absolutely. This specific murmur is frequently encountered in survivors of childhood surgery for conditions like tetralogy of Fallot or pulmonic stenosis pulmonary atresia. These repairs often leave some degree of PR behind, so it's a crucial finding to listen for in these individuals during their long-term follow-up.
Right.
What's also important to remember, though, is that in some cases, despite significant PR and substantial right ventricular volume overload, that diastolic murmur can be misleadingly low-pitched and kind of short.
The trap you mentioned earlier.
Exactly. It can be a trap because it doesn't always reflect the true severity. This happens when the RV diastolic pressure is really high, shortening the duration of that pressure gradient, making the murmur less prominent even when the condition is quite severe. You have to integrate all the findings.
Okay, moving beyond the physical exam, what about lab tests and imaging? How do clinicians definitively nail down the diagnosis of PR and assess its severity, especially when things get complex with multiple valves involved?
Well, on the electrocardiogram, the ECG, depending on the cause and severity, you might see signs of right ventricular hypertrophy, RVH, that muscle thickening, and maybe right atrial enlargement. A chest X-ray can also show evidence of RV and RA enlargement, and sometimes even dilation of the main pulmonary artery if PA pressures are high.
But the main tool is echo, right?
Yes, for definitive assessment, transthoracic Doppler echocardiography, or TTE, is really the workhorse. It gives you direct, real-time visualization of the pulmonic valve's morphology and how it's functioning. And crucially, it's used to non-invasively estimate the right ventricular systolic pressure by measuring the tricuspid valve systolic jet velocity. That helps us understand the pressure the RV is pumping against.
I recall reading that cardiac magnetic resonance, or CMR, is particularly good for looking at the right ventricle. Why is that?
You're absolutely right. Cardiac magnetic resonance, CMR, imaging is indeed superior for providing greater anatomic detail. This is especially true in patients with repaired congenital heart disease, where the anatomy can be complex, maybe distorted from surgery.
And it measures volumes better.
That's the key thing. What's truly unique and insightful about CMR is its ability to provide a more precise quantitative assessment of right ventricular volumes and function, the RVEF we talked about. Traditional echo can sometimes struggle with accurate RV assessment because of its complex sort of crescent shape.
Oh.
CMR, however, allows for highly accurate volumetric measurements of the RV. This is absolutely critical for guiding management decisions, determining prognosis, and especially timing for intervention, figuring out when that RV is starting to fail and needs surgical or, increasingly, transcatheter repair.
What about cardiac catheterization? Is that needed for diagnosis?
Usually not. Cardiac cath isn't routinely necessary for the initial diagnosis of PR in most cases. It's typically reserved for situations where it's performed as part of a planned transcatheter pulmonic valve procedure. It serves more as a procedural guide in those instances rather than a primary diagnostic tool.
Okay, so once PR is diagnosed and you know how severe it is, what are the treatment strategies? How do clinicians approach managing it?
It really depends on the cause. For patients with functional PR, remember, that's the type resulting from pulmonary artery hypertension and the subsequent annular dilation. The main therapeutic focus is on reducing the pulmonary artery vascular resistance and pressure.
Treat the underlying cause of the high PA pressure.
Exactly. This might involve medications like vasodilators or even surgical or interventional approaches, all depending on why the pulmonary hypertension is there. Is it idiopathic, meaning no known cause, or is it secondary to, say, left-sided heart valve disease? The core principle is addressing the root cause of that pressure overload.
Makes sense.
Additionally, diuretics are commonly used symptomatically. They help manage the manifestations of right heart failure, like the swelling and abdominal fullness we discussed earlier. Just helps get rid of the excess fluid.
What about fixing the valve itself?
A surgical valve replacement for primary severe pulmonic valve disease, so issues directly with the valve itself, like damage from carcinoid or endocarditis, is actually quite rare.
Really?
Yeah. The most significant advancement in treating severe PR, and this is interesting, it notably predates transcatheter aortic valve replacement, or TAVR, is transcatheter pulmonic valve replacement, TPVR. This minimally invasive procedure has been successfully performed in many patients, particularly those with severe PR after childhood repair of tetralogy of Fallot or pulmonic valve stenosis atresia. It has really revolutionized management for this specific, often young, patient population, offering a much less invasive option compared to open-heart surgery.
That's a truly comprehensive look at pulmonic regurgitation. Now let's pivot slightly. What about pulmonic stenosis, or PS? How do we diagnose and treat the narrowing?
For pulmonic stenosis, much like PR, transthoracic Doppler echocardiography, TTE, remains the definitive diagnostic tool. It lets us clearly visualize and characterize the pulmonic valve itself, see its morphology, how the leaflets are moving. We can accurately measure the jet velocity and calculate the pressure gradient across the valve, which tells us how severe the narrowing is.
And PA pressures should be low here, right? Since the blockage is before the PA.
Exactly, that's an important point. In isolated PS, we expect pulmonary artery pressures to be low. TTE also helps identify any associated cardiac lesions, which is crucial because PS often occurs with other congenital anomalies.
Any role for T, the transesophageal echo?
Yes, T can be useful in certain patients, especially for getting a clearer delineation of the right ventricular outflow tract, the RVOT, and sometimes to assess for infundibular hypertrophy. That's a thickening of the muscular wall just below the pulmonic valve that can also contribute to the obstruction.
And cardiac cath for PS necessary for diagnosis?
Generally, no. Cardiac catheterization isn't usually necessary for diagnostic purposes in PS. TTE typically gives us everything we need. However, if it is performed, it's primarily used to get very precise pressure measurements from just below and just above the pulmonic valve.
Any pitfalls there?
Well, it's crucial to pay close attention to the possibility of a dynamic component to the gradient. This means the pressure difference can change depending on things like heart rate or how forcefully the ventricle contracts. So you might need multiple measurements. And here's an interesting nuance. The correlation between the Doppler peak instantaneous gradient, the highest pressure difference, echo measures at one moment, and the catheterization measured peak-to-peak gradient. The difference between peak RV and peak PA pressure is actually quite weak.
Really? Which one is better?
The Doppler mean gradient, which averages the pressure difference over the whole ejection period, often correlates much better with the catheter-measured values. It's an important clinical pearl. You need to be careful interpreting and comparing numbers from different modalities.
Got it. That's good to know. So how is pulmonic stenosis typically treated, especially now with less invasive options available?
Similar to other valve conditions causing heart failure symptoms, diuretics can be used symptomatically. But the primary interventional treatment for PS, provided there isn't significant pulmonic regurgitation alongside it, less than moderate PR, is percutaneous pulmonic balloon valvuloplasty.
The balloon procedure.
Right. You insert a catheter with a balloon into the narrowed valve and inflate it to stretch open the leaflets. It's recommended for symptomatic patients with moderate or severe PS. And notably, it's also indicated for asymptomatic patients who have a significant peak gradient over 64 milliliters G or a mean gradient over 35 milliliters G.
Even without symptoms. Why?
Because that level of severity warrants intervention to prevent future complications, like RV dysfunction, even if the patient feels fine right now.
Okay. When is surgery needed?
Surgery might be required in specific cases, particularly when the valve is dysplastic. That means it's abnormally formed, maybe thickened and less pliable, making it less suitable for balloon dilation. You often see this in patients with Noonan syndrome or other genetic conditions affecting valve development.
And who makes these decisions?
Ultimately, for these complex decisions, especially when multiple factors are in play, a multidisciplinary heart team approach is really the best way. Getting cardiologists, surgeons, imagers all together to decide on the most appropriate, patient-specific treatment choice.
So we've now built a really strong foundation by exploring the individual intricacies of pulmonic valve disease, both PR and PS. But as you said earlier, this is just the starting point. Now it's time to plunge into the real maze, multiple and mixed valvular heart disease. This is where things get truly complex, isn't it? This is where we aim for that elite professional understanding.
This is indeed the core challenge, yeah. And where the nuances truly come to light.
Yeah.
When we talk about multiple and mixed valvular heart disease, we're referring to conditions involving either stenosis, that narrowing, and the regurgitation, the leakage, affecting one or more heart valves.
Multiple valves, multiple problems.
Exactly. It's not just one door with one issue. It's multiple doors, often with multiple and interacting issues. It profoundly affects the entire circulatory system. Mastering this really involves understanding the synergy and sometimes, frankly, the antagonism between these different lesions.
And what are the most common culprits behind these complex scenarios? What sets the stage for multiple valves to go wrong?
Historically, and still very relevant globally, is rheumatic heart disease. It's a systemic inflammatory disease, usually following strep throat in childhood, that can lead to chronic, progressive damage to heart valves over decades.
And it hits multiple valves.
It can have a broad impact, yes. It can involve the mitral valve, the aortic valve, and the tricuspid valve. You might see mitral stenosis, mitral regurgitation or mixed mitral disease, aortic stenosis, aortic regurgitation or mixed aortic disease, and tricuspid stenosis, tricuspid regurgitation, or mixed tricuspid disease alone, or in various, often quite intricate combinations. This is why getting a thorough history, especially about childhood illnesses, is so vital.
So something like rheumatic fever from childhood can really set someone up for a lifetime of these complex valve issues. What are some other common associations we frequently see?
A very, very common clinical scenario is functional tricuspid regurgitation, or TR, occurring alongside significant mitral valve disease.
Functional TR again. So the tricuspid valve itself is okay.
Right. The TR here isn't due to a primary problem with the tricuspid valve leaflets. It's a secondary consequence. The pressure and volume overload on the right ventricle, caused by the left-sided mitral valve issue backing blood up into the lungs, leads to dilation of the RV and its valve annulus, causing the leak.
Okay. What else?
Another one, often overlooked but increasingly recognized, is severe mitral annular calcification, or MAC. This calcification of the fibrous ring around the mitral valve can actually lead to both regurgitation, because the stiff annulus can't shorten properly during systole, and mild to moderate stenosis, as the calcium can extend onto the valve leaflets themselves, restricting their opening. So MAC can cause mixed disease.
And it's not always just a primary valve problem itself, right? I'm thinking about conditions affecting the ventricles or even infections spreading.
Absolutely. The interplay between the chambers and the valves is absolutely critical. For instance, patients with severe aortic stenosis that puts a huge pressure overload on the left ventricle, right? That pressure causes significant left ventricular remodeling changes in its size and shape. This stress can actually lead to chordal rupture. The chordae tendineae are those delicate heartstrings supporting the mitral valve leaflets. If they snap under the strain, boom, you get acute mitral regurgitation, complicating the primary aortic stenosis.
Wow. And infections.
Another dramatic mechanism is aortic valve infective endocarditis, i.e., this infection can secondarily involve the mitral valve apparatus in a couple of ways. It can spread directly through abscess formation, tunneling from the aortic valve through the intervalvular fibrosa. There's this fibrous tissue connection between the aortic and mitral valves.
Okay.
Or you can get what we call drop metastases. Literally, infected clumps, vegetations from the aortic leaflets break off, fall down, and land on and infect the interior leaflet of the mitral valve. It's a vivid, scary illustration of how infection can bridge structures.
That's quite a mechanism. Are there other systemic conditions or even treatments that can broadly hit multiple valves?
Yes, unfortunately. Mediastinal radiation, often used for cancer treatment in the chest area, can lead to mixed aortic, mitral, and even tricuspid valve disease over time. It often presents as a combination of stenosis and regurgitation. The radiation causes fibrosis, scarring of the valve tissue.
Okay.
Carcinoid heart disease, which we mentioned earlier affecting the pulmonic valve, specifically impacts the tricuspid and pulmonic valves. It often causes a mixture of stenosis and regurgitation because those vasoactive substances produced by the tumor mainly affect these right-sided structures.
Any medications?
Rarely, certain meds like ergotamines or that previously used weight loss combo of fenfluramine and phentermine, fen, have been associated with fibrotic changes leading to mixed aortic and/or mitral valve lesions.
And then there are the genetic predispositions, the connective tissue disorders. I imagine they can affect the integrity of valve tissue pretty broadly.
Precisely. Patients with connective tissue disorders often have a predisposition to multivalve disease. Take Marfan syndrome, known for its impact on connective tissue. It can lead to both aortic regurgitation, often due to aortic root dilation where the base of the aorta widens, and mitral regurgitation stemming from mitral valve prolapse, where the leaflets get floppy and bulge back into the left atrium.
So multiple valves affected by the underlying tissue weakness.
Right. And even without a clear, named connective tissue disorder, you can have myxomatous degeneration. This is where the valve tissue itself becomes floppy, redundant, and weakened. It can cause prolapse and regurgitation of multiple valves: mitral, aortic, and tricuspid.
Okay.
Finally, having a bicuspid aortic or pulmonic valve borne with 2 leaflets instead of 3 can obviously lead to mixed stenosis and regurgitation in that specific valve. But the bicuspid aortic valve in particular is also strongly linked to aortic aneurysm disease, dilation of the aorta itself, and a predisposition to aortic dissection. That adds another, potentially life-threatening layer of complexity that impacts management way beyond just the valve itself.
This sounds incredibly challenging just from a diagnostic standpoint. How does the pathophysiology of having multiple and mixed valve disease complicate things even further? You said it's not just an additive effect.
That's the really fascinating and often deceptive part. It's rarely just additive. It's frequently a masking effect. The pathophysiologic problems caused by a more proximal valve disease, one earlier in the flow path, can subtly, or sometimes quite dramatically, mask the full hemodynamic expression of a more distal valve lesion, one further downstream.
Can you give an example of that masking?
Sure. Let's take a clinical example.
Mm.
A patient with both rheumatic mitral valve disease and aortic valve disease. If the mitral stenosis or regurgitation is significantly reducing the overall cardiac output, less blood getting through the mitral valve,
Yeah.
then that reduced forward flow will actually decrease the magnitude of the hemodynamic derangements related to the severity of the aortic valve lesion, whether it's AS, AR, or both. The aortic problem might seem less severe than it truly is, simply because there isn't enough blood flowing across it to demonstrate its full impact.
So one problem literally hides the other, making it much harder to gauge the true severity. How do clinicians actively look for this masking effect? Or are they often surprised by it?
This is a critical clinical pearl. Yeah. Seasoned clinicians are always on the lookout for this. It's why an integrated assessment, looking at the whole patient picture beyond just isolated valve numbers from an echo, is absolutely paramount.
What do they look for?
They'll look for subtle symptoms that don't quite fit the apparent severity of the main valve problem, or maybe changes in symptoms over time that seem out of proportion. Sometimes, actually treating the seemingly dominant lesion first will suddenly unmask a previously underestimated second lesion. It's a very common diagnostic pitfall, especially if you rely solely on an isolated valve gradient without considering the global cardiac output.
And what about the impact of arrhythmias like atrial fibrillation in this context? I imagine a chaotic rhythm could suddenly throw everything off balance.
Oh, absolutely. This raises a vital point. Atrial fibrillation, AF, is a prime example of something that can suddenly and dramatically worsen a multi-valve situation. Think about a patient with mitral stenosis and maybe coexisting but perhaps underestimated aortic valve disease.
Okay.
If they suddenly flip into AF, it can lead to a sudden critical deterioration. Why? Well, first, you get the loss of atrial systole. Normally, the atria contract just before the ventricles, giving this crucial atrial kick that primes the ventricles with extra blood. In AS, that coordinated kick is gone.
Right, it's just fibrillating.
Exactly. Second, the heart rate often becomes rapid and irregular. So the combination of losing that atrial kick and having a fast, chaotic rhythm critically reduces forward cardiac output. And at the same time, it significantly raises left atrial and left ventricular diastolic pressures. The filling pressures skyrocket.
And that leads to...
That sudden pressure increase and fall in output can precipitate acute heart failure. It can make a previously stable, maybe even asymptomatic, patient acutely ill very quickly. This is why vigilance for arrhythmias in multi-valve disease is so crucial.
And then there's this concept you mentioned, a secondary obstructive lesion in series. What does that mean in the context of multivalvular disease?
Okay, that refers to the development of reactive pulmonary vascular disease. Imagine the heart pumping against multiple obstacles for a long time. If you have long-standing left-sided heart valve disease like severe mitral or aortic issues, it causes elevated pressures backing up into the pulmonary circulation, the blood vessels in the lungs.
Right, pulmonary hypertension.
Exactly. But over time, those pulmonary blood vessels can themselves become diseased. They can stiffen and narrow due to the chronic high pressure. This adds further resistance and burden to the right side of the heart. So this secondary obstructive lesion in series means the poor right ventricle now has to pump against two obstacles, the original left-sided valve problem and this newly resistant pulmonary circulation.
Double whammy for the RV.
Precisely. And this compounds the masking effect we discussed earlier. A fall in cardiac output due to progressive right-sided issues, like developing severe tricuspid valve disease, can lead to a significant underestimation of the severity of any associated mitral or aortic disease upstream. The heart simply isn't pumping enough blood forward to fully demonstrate how bad those downstream valve issues really are.
Let's delve into some key examples to really solidify this. What's one of the most common and illustrative examples of multi-valve disease and how it manifests?
Okay, one of the most common and clinically relevant examples is that functional tricuspid regurgitation, functional TR, occurring in the setting of significant mitral valve disease. We touched on it, but let's unpack it.
Right, the TR happens because of the mitral problem.
Exactly. This functional TR develops as a consequence of the right ventricle and its valve annulus, that fibrous ring dilating, stretching out. This dilation often happens because the left-sided mitral valve disease caused blood to back up into the lungs, leading to pulmonary hypertension, which then strains the right side. The crucial point again, the tricuspid leaflets themselves are morphologically normal. They're not diseased, but they just can't co-opt or close effectively because the ring they're attached to is stretched too much.
So the valve structure is fine, but the goalposts have moved, basically. The chambers around it are so stretched the valve can't close properly, leading to that leak. How does that progress, and what are the specific physical findings?
Well, this progressive degree of TR leads to chronic right ventricular volume overload, and this in turn causes continued chamber and annular dilation. It's a vicious cycle.
It gets worse and worse.
Right. The TR itself is typically central in origin, meaning the leak is happening in the middle of the valve, not usually at the edges where the leaflets meet the ring. Now, the reflex of blood back into the right atrium during systole is expressed clinically as large systolic CV waves in the right atrial pressure pulse if you were measuring it invasively.
What are CV waves?
They're specific pressure spikes seen in the right atrium during ventricular contraction, reflecting that significant backflow of blood. The height of these waves depends on how compliant or stretchy the right atrium is and just the sheer volume of regurgitant flow. In really advanced stages of chronic severe TR, the right atrial waveform can even become ventricularized.
Meaning?
Meaning it starts to look like a ventricular pressure waveform because the pressures in the right atrium are so high and pulsatile due to the massive backflow. It indicates very high and damaging pressures within the RA.
And this must dramatically affect cardiac output, bringing us back to that masking effect for the left-sided lesions, right?
It absolutely does. As cardiac output falls, because the right ventricle is failing under the TR load, the severity of the associated mitral valve disease may become much more difficult to appreciate on standard hemodynamic measurements like echogradients. Clinically, findings related to advanced right heart failure like ascites, fluid in the abdomen, and widespread edema or swelling often predominate. They might overshadow symptoms from the original left-sided issues.
So the patient presents with right heart failure symptoms, but the root cause started on the left.
Often, yes. And it's crucial here to distinguish this functional TR from primary rheumatic tricuspid valve disease, which can coexist with rheumatic mitral disease. Primary rheumatic disease of the tricuspid valve can cause its own hemodynamic changes, TR, tricuspid stenosis, TS, or both. With TS, for instance, you'd typically see a prolonged wide descent in the RA pressure pulse, reflecting slow emptying of the RA. Making that distinction is vital for proper diagnosis and deciding on the right surgical approach, if needed.
Okay. Another complex scenario is the interplay between mitral and aortic valve pathology, especially when you have, say, mitral stenosis and aortic regurgitation coexisting. How do those two interact?
Yeah, that's a classic challenging combination. Think about it. In a patient with isolated mitral stenosis, the left ventricular preload, the filling volume, and diastolic pressure are typically reduced because inflow into the LV is obstructed at the mitral valve.
Right, less blood gets in.
But if you have concomitant aortic regurgitation, blood is leaking back into the left ventricle from the aorta during diastole. This means the left ventricular filling is actually enhanced by that backward leak, and its diastolic pressure may rise depending on how compliant or stiff the LV chamber is. The LV is getting blood from two directions during diastole, essentially.
And given what we discussed, the mitral stenosis can mask the aortic problem here too, right? Because less blood is reaching the aorta in the first place to leak back.
Precisely. This is a critical point for clinical understanding. Because the cardiac output falls with progressive degrees of mitral stenosis, the forward flow across the aortic valve declines. This effectively masks the potential severity of the aortic valve lesion, whether it's AR, AS, or mixed. The aortic valve just isn't experiencing its full volume or pressure load, so its dysfunction might appear less severe than it really is.
Okay.
And again, as we noted before, the onset of atrial fibrillation in these patients can be especially deleterious. Losing that atrial kick with AF can result in a critical drop in cardiac output, a significant rise in LA and LV diastolic pressures, and that detrimental increase in heart rate. This combination dramatically increases lung pressures and can precipitate acute heart failure. Makes these patients very fragile.
Let's look at a very common complication now. Secondary or functional mitral regurgitation complicating severe aortic stenosis. How does that arise and what's its clinical significance?
Okay. Secondary or functional mitral regurgitation frequently complicates the course of patients with severe aortic stenosis. Again, functional means there isn't necessarily a primary problem with the mitral valve leaflets themselves.
So what causes it?
It occurs in the context of markedly elevated left ventricular systolic pressures. That's the hallmark of severe aortic stenosis. This chronic intense pressure overload leads to significant changes in the LV geometry and function. The ventricle becomes stiff, hypertrophied, its shape can distort. And this distortion pulls on the mitral valve apparatus, the leaflets, the annulus, the papillary muscles, causing the mitral valve to leak, even though its structures might be intrinsically normal. It's a consequence of the ventricle struggling under the huge burden of the aortic stenosis.
So it's not a primary mitral valve problem, but a direct result of the severe AS. Does treating the AS, like with valve replacement, usually fix the MR too? Or does the MR need its own intervention?
This is a key clinical decision point. Often, yes. Relieving that excess afterload on the left ventricle, taking away the pressure burden, typically through surgical aortic valve replacement, AVR, or transcatheter aortic valve replacement, TAVR, can result in a significant reduction or sometimes even complete resolution of this secondary mitral regurgitation.
Why?
Because the ventricle remodels positively once the pressure burden is lifted. Its shape normalizes somewhat, allowing the mitral valve leaflets to coapt to close together better.
But not always.
Not always, and this is a crucial insight.
Yeah.
The persistence of significant secondary mitral regurgitation after aortic valve replacement is associated with impaired functional outcomes and reduced long-term survival.
Okay, so leaving it behind is bad prognostically.
Yes. This raises a challenging question for clinicians. Identifying which patients would truly benefit from concomitant treatment of their secondary MR at the time they get their aortic valve replaced. Most surgeons, recognizing this prognostic implication, now advocate for repairing moderate to severe or severe secondary MR during surgical AVR, usually with an annuloplasty ring, to try and improve those long-term outcomes. It adds relatively little risk to the primary operation in experienced hands.
And what if the mitral regurgitation is primary, not secondary, like due to prolapse? Is that handled differently when someone also needs AVR?
Oh, yes. If significant primary mitral regurgitation, meaning a structural problem with the mitral valve itself, like prolapse or chordal rupture, coexists with aortic stenosis requiring AVR, it is routinely managed with repair or replacement at the time of the AVR. That's considered a clear indication for a combined intervention. What's also a rapidly evolving and exciting area is the increasing experience with combined transcatheter procedures, doing a TAVI for the AS, and then also doing a transcatheter edge-to-edge mitral repair, or TEER-like, with a MitraClip device for the MR.
So both valves fixed percutaneously.
Exactly. This innovative approach is being increasingly used for high surgical risk patients who present with both severe AS and severe primary or secondary MR. It offers a less invasive option for these very complex cases that might otherwise have been deemed inoperable.
Now, assessing mixed stenosis and regurgitation, whether it's aortic or mitral, sounds like a real diagnostic puzzle. How does the presence of regurgitant flow influence how we assess the severity of the stenosis part? Does it make it harder to get accurate measurements?
It creates a significant and often quite deceptive diagnostic challenge. Let's take mixed aortic stenosis and aortic regurgitation. The augmented systolic flow velocities, meaning faster blood flow going out during contraction, because you have the normal forward flow plus the volume that leaked back.
Right, higher stroke volume.
Exactly. Especially if LV function is preserved. This faster flow can artificially elevate the left ventricular aortic Doppler-derived pressure gradients. It makes the stenosis appear more severe than it truly is by overestimating the pressure difference needed to push that higher volume out. It can also increase the intensity of the systolic murmur you hear, further potentially misleading the clinician.
So the Doppler numbers might be misleadingly high, making the stenosis seem worse than it is.
Correct.
And this must directly impact other calculations, like the Gorlin formula for valve area.
Exactly right. The Gorlin formula, which is commonly used in the cath lab to calculate valve area, relies on measuring forward cardiac output and the mean pressure gradient across the valve. It becomes inaccurate in the setting of mixed aortic valve disease.
Why?
Because it doesn't adequately account for that regurgitant flow distorting the relationship between flow and gradient. It's designed for isolated stenosis, and the mixed flow invalidates its core assumptions. And similar considerations apply to patients with mixed mitral valve disease. An increased peak mitral valve Doppler E wave velocity that's V0, reflecting early diastolic flow into the LV, which might be high due to severe mitral regurgitation, can inaccurately reflect the contribution to left atrial hypertension from any associated mitral stenosis. Again, it can make the stenosis appear more severe hemodynamically than it is anatomically, because the sheer volume of regurgitant flow returning to the LA is artificially increasing that filling velocity.
So if the numbers themselves can be deceptive, how do you get a handle on which lesion is actually dominant? Is there a physical clue or a way to integrate the information?
A critical physical and especially imaging clue can be the left ventricular chamber size. Think about it. If either aortic regurgitation or mitral regurgitation is the dominant lesion in patients with mixed aortic or mitral valve disease, the left ventricle will typically be dilated. It has to stretch to accommodate that extra volume load over time.
Makes sense. Volume load leads to dilation.
Conversely, if aortic stenosis or mitral stenosis predominates, the left ventricular chamber size will usually be normal or even small, because the forward flow is restricted, and the primary stress is pressure, not volume.
Pressure load leads to hypertrophy, maybe without dilation initially.
Exactly. While it can sometimes still be difficult to definitively ascertain whether stenosis or regurgitation is the truly dominant lesion, an integrated clinical assessment combining the symptoms, the physical exam, and comprehensive non-invasive imaging, particularly a good echo, can usually provide enough clarity for patient management decisions.
Okay.
And it's worth noting, for patients with moderate mixed AS and AR, where the stenosis part is clearly dominant hemodynamically, the natural history tends to parallel what you'd expect for isolated severe aortic stenosis. The treatment approach often aligns with that.
This sounds like such a precarious balance the heart has to maintain. What happens if an already stressed heart, like one with significant AS and maybe that concentric hypertrophy, suddenly has to deal with acute AR? That sounds like a recipe for disaster.
Yeah. It is. That's a critical and often catastrophic scenario. Patients with significant aortic stenosis, especially those with a non-dilated LV chamber, and that concentric hypertrophy where the muscle wall thickens inward, making the chamber smaller and stiffer, will tolerate the abrupt development of significant aortic regurgitation very poorly.
How might that happen acutely?
Well, it could happen with infective endocarditis causing acute valve destruction, tearing a leaflet, or maybe after surgical AVR or TAVI if there's a new significant paravalvular leak, a leak around the implanted valve.
Okay.
The non-compliant left ventricle, already stiff and hypertrophied from the chronic pressure overload of the AS, is simply not prepared to handle this sudden large volume load from the acute AR. As a result, the left ventricular diastolic pressure rises rapidly, sometimes catastrophically, leading to severe acute heart failure, often pulmonary edema.
And that paravalvular leak after TVI, that's a known risk factor.
Yes. Moderate or severe paravalvular regurgitation itself is a significant risk factor for short to intermediate term death following transcatheter AVR. It highlights the immediate and severe hemodynamic impact these leaks can have, especially in a heart already compromised by stenosis.
Are there any conditions that might prevent the heart from even being able to dilate or stretch properly in response to chronic regurgitation, making it even more vulnerable?
Yes, there are specific clinical situations that limit the ventricle's ability to adapt through dilation. Conditions where the left ventricle may not dilate effectively in response to chronic AR or MR include radiation heart disease. The radiation causes myocardial fibrosis, making the heart muscle stiff and non-compliant. And also, in some patients, the cardiomyopathy associated with severe obesity and diabetes can lead to a similar picture, a stiff, non-dilated ventricle. These non-compliant ventricles, which might maintain a relatively small chamber size despite chronic volume overload, are predisposed to an earlier onset of diastolic dysfunction and heart failure symptoms in response to any further perturbation in valve function, like worsening regurgitation. It highlights their inherent vulnerability and the need for perhaps earlier intervention.
Given all this incredibly intricate pathophysiology, how do the symptoms and physical findings of multivalvular disease differ from isolated single lesion problems? Are there unique clues clinicians look for?
Well, one key difference is timing. In comparison to patients with isolated single lesion valve disease, patients with multiple or mixed valve disease may develop symptoms at a relatively earlier stage in the natural history of their disease.
Why is that?
It's a crucial insight. The cumulative burden on the heart is simply greater when multiple valves are involved. It just tips them into symptomatic territory sooner. Common symptoms like exertional dyspnea, shortness of breath with activity and fatigue are usually related to elevated filling pressures in the heart, reduced cardiac output, or often a combination of both. The heart is just struggling to keep up with the demands placed upon it by multiple faulty valves.
And what about other, perhaps more specific symptoms? Palpitations, chest pain?
Palpitations can be a really significant clue. They often signify the presence of atrial fibrillation, as we've discussed. And finding AF, especially in someone presenting mainly with aortic valve issues, might strongly suggest previously unsuspected mitral valve disease as an important component, because AF is so common with mitral problems.
Okay, so AF points towards looking at the mitral valve more closely. What about chest pain?
Chest pain, compatible with angina, is also common. This pain can reflect a mismatch between the ventricular oxygen supply and demand. You've got this substrate of ventricular hypertrophy, thickened muscle, needing more oxygen and chronic pressure or volume overload stressing the system, even without significant coronary artery disease. Though, of course, CAD can coexist and contribute.
And the right heart failure symptoms.
Symptoms specifically related to right heart failure, like that abdominal fullness or bloating from liver congestion and lower extremity swelling or edema, those are typically late manifestations. They indicate advanced disease where the heart is truly struggling to maintain forward flow and fluid is backing up throughout the body.
Okay, on physical examination now, what distinct findings might clinicians observe with mixed disease of a single valve? How do they sort out all the different sounds?
Mixed disease of a single valve is most often manifested by hearing both systolic and diastolic murmurs originating from that valve. For example, with mixed aortic valve disease, you typically hear a systolic crescendo decrescendo murmur. That's the sound of blood pushing through the narrowed aortic valve, the AS component. And a blowing decrescendo diastolic murmur, the sound of blood leaking backward to the the air component. Both are best heard at the base of the heart. Typically the systolic one at the second right interspace and the diastolic one along the left sternal edge.
But you said earlier AR alone can cause a systolic murmur.
That's an important point of confusion, yes. Many patients with significant aortic regurgitation alone can have mid-systolic outflow murmurs just due to the high volume of blood being ejected across the valve, even without any actual valve sclerosis or stenosis. So clinicians must actively seek other findings of aortic stenosis, like a palpable thrill over the valve, or delayed carotid upstroke, pulsus parvis et tardus, to truly differentiate flow murmurs from true stenotic murmurs.
That sounds like it could be really confusing. How do you distinguish between these complex aortic murmurs and, say, a continuous murmur, like one from a patent ductus arteriosus, PDA?
It can be quite tricky, yeah. It demands a very skilled ear and careful timing. The separate murmurs of AS and AR can occasionally be difficult to distinguish from truly continuous murmurs, like those associated with a PDA or maybe a ruptured sinus of Valsalva aneurysm.
What's the key differentiator?
A key differentiator for mixed aortic valve disease is that the systolic murmur should end before the second heart sound, S2. It shouldn't envelope or extend through S2.
Okay.
A PDA murmur, by contrast, is classically a continuous machinery-like murmur, best heard usually to the left of the upper sternum, and it does extend right through S2. The continuous murmur heard with a ruptured sinus of Valsalva aneurysm often starts after an episode of acute chest pain and has its own specific quality and location.
Any other subtle clues for mixed aortic disease?
Well, the absence of an early ejection click can be relevant. An ejection click usually defines bicuspid aortic valve disease in young adults, indicating mobile leaflets. Its absence in someone with congenital mixed AS and AR might suggest the leaflets are more significantly diseased or fused.
And what about the overall impact of cardiac output on these murmurs? We talked about how low output can mask severity.
Yes, absolutely. As we discussed regarding the masking effect, the intensity and duration of these separate murmurs can be significantly influenced, often diminished, by a reduction in cardiac output and transvalvular flow, especially if there's coexistent mitral valve disease, lowering the amount of blood reaching the aorta. Less flow across a valve means a quieter, less intense murmur, potentially leading to an underestimation of the true severity.
Okay. What about mixed mitral disease?
For patients with isolated mixed mitral stenosis and mitral regurgitation, you'd expect to find a blowing holosystolic murmur, that's the MR, heard throughout systole and in mid-diastolic rumble, maybe with or without an opening snap, that's the MS. Both are best heard down at the cardiac apex. And of course, hearing an irregular heart rhythm in such patients would strongly suggest atrial fibrillation, which is extremely common with significant mitral valve disease.
So it's really about piecing together this complex auditory puzzle. What about the right-sided valves, tricuspid and pulmonic? Do their mixed murmurs behave similarly to their left-sided counterparts?
Yes, generally speaking, findings with mixed tricuspid stenosis and tricuspid regurgitation would largely mimic those of left-sided MS and MIR, but with that one critical differentiating feature, their response to respiration.
Louder with inspiration.
Exactly. Right-sided murmurs typically become louder with inspiration as more blood flows into the right side of the heart. And similarly, The murmurs of mixed pulmonic stenosis and regurgitation behave in a fashion directionally similar to AS and AR, again with those dynamic changes during respiration being crucial for localization. For instance, the PS murmur might increase with inspiration, while AS wouldn't. These respiratory changes are vital tools in differentiating right-sided from left-sided murmurs when things get confusing.
Okay, let's dive into the laboratory examination for multivalvular disease now. Beyond the physical exam, what are the crucial diagnostic tools clinicians rely on? Maybe start with the electrocardiogram, the ECG.
The ECG, while basic, can provide vital initial clues in this complex landscape. It might show evidence of ventricular hypertrophy, that muscle thickening in either the left or right ventricle, and/or atrial enlargement, indicating the collecting chambers are working harder or are dilated.
Any specific patterns to look for?
What's particularly insightful is finding ECG signs that point to right-sided cardiac abnormalities like RVH or right atrial enlargement in patients who primarily present with what seems like left-sided valve lesions. That should immediately prompt additional assessment for pulmonary artery hypertension and the GDOR coexisting right-sided valve disease. It's a critical diagnostic alert. Why is the right side involved?
Okay.
Furthermore, as we mentioned, the presence of atrial fibrillation in patients with known aortic valve disease might be a strong clue to previously unsuspected mitral valve disease, especially when you correlate it with the clinical context.
So the ECG acts like a detective, maybe pointing towards hidden problems. What about the chest X-ray? What insights can that provide?
The chest X-ray, though a simple image, can offer significant clues. You look for evidence of cardiac chamber enlargement. Is the heart silhouette bigger than expected? You look for valve and/or annular calcification, which can indicate long-standing, often degenerative valve disease. And importantly, it can reveal abnormalities in the pulmonary vasculature, like enlargement of the main and proximal pulmonary arteries, which strongly suggests pulmonary artery hypertension. Or signs of pulmonary venous redistribution or engorgement vessels in the upper lungs look more prominent, or even those curly B lines, short, thin lines out in the periphery. All of those indicate increasing degrees of left atrial hypertension, blood backing up from the left side.
Anything else on the X-ray?
An enlarged azygos vein, seen on the frontal view, is a sign of right atrial hypertension, indicating systemic venous congestion. Really, the bottom line is any rulongenographic findings that are not expected based on what you think is the single or mixed valve lesion should raise suspicion for other coexisting valve disease. It's about looking for the unexpected pieces of the puzzle.
And then the real workhorse of cardiac imaging, transthoracic echocardiography, or TTE. This is where a lot of the definitive answers come from, right?
Absolutely. TTE is undeniably the most commonly used and arguably the most crucial imaging modality for diagnosing and comprehensively characterizing multiple and/or mixed valvular heart disease. It's invaluable because it so often demonstrates findings that were not clinically suspected. It's a critical screening and diagnostic tool.
What are the key things you're looking for in TTE here?
Key findings include detailed information on valve morphology, the leaflet structure and function, the presence and extent of calcification, precise measurements of chamber size, ventricular wall thickness, a comprehensive assessment of biventricular function, how well both ventricles are pumping, like LVEF and RVEF, estimated pulmonary artery systolic pressure, and the dimensions of the great vessels, the aorta, PA, IVC. It gives you that whole picture.
So it's a comprehensive overview that helps identify multiple issues. What if the TTE performed at rest doesn't fully explain why the patient feels so limited?
That's a great question. In such cases, exercise testing, often with echocardiography performed immediately before and after exercise, stress echo, can be very useful. If a patient reports significant functional limitation, like getting breathless easily, but their rest TTE doesn't seem severe enough to explain it, an exercise echo might reveal dynamic changes. Maybe the gradients across a valve increase dramatically with exertion, or pulmonary pressure shoot up, things that only become apparent under stress.
I see.
An integrated assessment of all the clinical findings, symptoms, exam, and the TTE results, rest and possibly stress, is essential. It helps determine the dominant valve lesion or lesions and establish the appropriate plan for treatment and follow-up. It's crucial to remember the natural history. The prognosis is usually influenced more by the dominant lesion, so identifying that is paramount for guiding management.
Are there situations where TTE just isn't enough and you need to go for a more invasive echo, the T?
Yes, definitely. Transesophageal echocardiography, TE, may sometimes be required for a more accurate and detailed assessment of valve anatomy. particularly the mitral valve, which sits deeper in the chest and can be harder to see perfectly from the front with TTE. T is also indispensable when infective endocarditis is suspected clinically. It offers much superior resolution in views of vegetations or abscesses on valve structures, which is critical for diagnosis and planning treatment, often surgery.
And what about the advanced imaging modalities like cardiac MRI and CT angiography? Where do they fit into this complex picture?
Cardiac magnetic resonance, CMR, can be used to provide additional anatomic and physiologic information when echo is maybe suboptimal, or when you need really precise ventricular volumes and function, especially for that tricky right ventricle. However, it's generally less good at evaluating calcification compared to CT. Importantly, though, CMR is invaluable in planning for complex transcatheter valve implantation procedures. It gives highly precise anatomical measurements of the valve annuli and surrounding structures like coronary artery height, which are critical for choosing the right device size and planning deployment.
And CT.
Coronary CT angiography offers a non-invasive alternative to catheterization for assessing coronary artery anatomy before any planned surgical or transcatheter valve intervention. It's crucial to rule out coexisting coronary artery disease, as that significantly impacts surgical planning, risk, and overall prognosis in these patients.
Finally, when do you actually need to get truly invasive with right and left heart catheterization for diagnosis or assessment in multivalvular disease? It sounds like imaging does most of the work now.
Imaging does a huge amount, but cath still has a role. Invasive hemodynamic evaluation with right and left heart catheterization may be required to characterize more completely the individual contributions of each lesion, especially when there's a significant discrepancy between the clinical findings and the non-invasive imaging results in the symptomatic patient. If the echo just doesn't seem to match how sick the patient feels, a cath can provide definitive pressure and flow measurements.
What specifically are you looking for in the cath?
Measurement of pulmonary artery pressures and a careful calculation of pulmonary vascular resistance, PVR, can provide crucial insights. This is particularly important in patients with advanced mitral and tricuspid valve disease, as it helps identify any significant contribution to the clinical picture from intrinsic pulmonary vascular disease, not just back pressure from the valves. Making that distinction is vital for determining prognosis and the potential benefit or futility of valve intervention.
And cardiac output measurement is key here too.
Absolutely essential during the procedure. Accurate assessment of cardiac output is critical, as it directly impacts all the calculated gradients and resistances. Coronary angiography, if needed to check for blockages, can be done at the same time. Contrast ventriculography and great vessel angiography, injecting dye, are performed much less frequently now, given how good non-invasive imaging has become.
Okay, so after all that meticulous diagnostic work, we finally arrive at treatment. Managing patients with multiple and mixed valve disease sounds inherently challenging given all the masking effects and complex interactions. How do clinicians even begin to approach it when the standard textbook guidelines for single valves might not fit neatly?
It is indeed one of the most highly challenging areas in cardiology. It requires a very integrated, holistic approach. As we've discussed, a helpful first step, if possible, is to definitively determine the dominant valve lesion, which problem is causing the most trouble right now. Once that's identified, clinicians can then largely follow the specific treatment and follow-up recommendations for that dominant lesion, using guidelines for single valve diseases as a starting point. However, and this is really where that elite professional insight comes in, it's absolutely crucial to remain mindful of potential deviations from the expected course because of the significant contributions from the other valve lesions.
Can you give an example of that deviation?
Sure. We talked about atrial fibrillation emerging in someone with seemingly moderate mitral valve disease. That AF might suddenly precipitate acute heart failure in a patient who also has severe aortic valve disease that was previously asymptomatic. The presence of that second lesion fundamentally alters the clinical presentation, the prognosis, and the urgency of management. It's really as simple as just fixing one problem in isolation when multiple are present.
So it's a dominant lesion approach, but with this critical awareness of the interplay and the potential for rapid decompensation. What about medical therapies? Are they broadly effective for these complex patients, or is it mostly about intervention?
Medical therapies are generally quite limited in their ability to definitively treat the underlying valve pathology in this context. They primarily serve to manage symptoms and complications, kind of supportive care.
Like what?
These include diuretics, when indicated, for relief of congestion, helping to offload the stressed heart. Anticoagulation is vital to prevent stroke and thromboembolism in patients with atrial fibrillation, which, as we've noted, is a common and dangerous complication here.
What about blood pressure meds?
Blood pressure-lowering medications may be necessary to treat systemic hypertension, especially since high blood pressure can significantly aggravate left-sided regurgitant valve lesions, like AR or MISR.
Oh.
But they must be initiated and titrated very, very carefully. These patients can be hemodynamically sensitive, and dropping their pressure too much or too quickly can be problematic.
Any role for pulmonary vasodilators?
Generally, no. It's important to understand that pulmonary vasodilators, drugs specifically aimed at lowering pulmonary vascular resistance, like those used in primary pulmonary arterial hypertension, are generally not effective in this particular context of pulmonary hypertension secondary to left-sided valve disease. Their role is very limited here.
Okay, so when do we move beyond medical management to intervention? Whether it's surgery or transcatheter, are there clear guidelines for these complex mixed and multiple valve patients?
That's a major challenge. There's a notable paucity, a lack of robust, large-scale evidence to inform specific practice guidelines for surgical and/or transcatheter valve intervention in patients with multiple or mixed valve disease.
So less clear rules.
Much less clear than for single valve disease. When there is a clear dominant lesion, say severe AS with only mild AR, the indications for intervention are relatively straightforward and generally follow those recommended for isolated severe AS.
But when it's more balanced or multiple valves are moderately bad?
Exactly. In other patients where the picture is less clear or where multiple lesions are contributing significantly, decisions regarding intervention must be very carefully based on several considerations. These include the overall assessed severity of all the affected valves, the degree of ventricular remodeling, how much the heart chambers have changed, the patient's functional capacity, how limited are they, and their pulmonary artery pressures.
And the threshold might be lower.
Yes, it's vital to recognize that patients with multiple and/or mixed valve disease may develop limiting symptoms or signs of physiologic impairment, even with valve lesions that, in isolation, might only be considered moderate. The cumulative burden is what pushes them over the edge sooner. The threshold for intervention might need to be lower.
So considering surgery, what about the risks of combined procedures, like doing both an aortic and a mitral valve replacement at the same time? That sounds like a massive operation.
It truly is a major undertaking. Concomitant aortic and mitral valve replacement surgery is associated with a significantly higher perioperative mortality, the risk of dying around the time of surgery compared to replacing either valve alone. Therefore, such a major operation has to be very carefully considered, weighing the risks and benefits thoroughly in a heart team discussion.
When is double valve replacement typically done then?
It's usually performed for the treatment of severe and often unrepairable valve disease at both locations. Or, it's sometimes considered for the combination of severe disease at one valve with moderate disease at the other, with the crucial goal being to avoid the hazards and high risks of needing a reoperation later on for a progressive disease of the unoperated moderate lesion. Going back in for a second sternotomy is considerably riskier.
Does having one valve already replaced make the second one harder?
Yes, the presence of a prosthesis already in the aortic position, for example, can significantly restrict the surgeon's exposure and access to the native mitral valve, adding technical complexity. The need for double valve replacement might also influence the decision on the type of prosthesis used, mechanical versus tissue, due to durability and anticoagulation considerations.
And what about tricuspid valve repair? Is that often done routinely now with left-sided valve surgery, given how often functional TR occurs?
Yes, absolutely. Tricuspid valve repair for moderate or severe secondary or functional TR at the time of left-sided valve surgery, like mitral or aortic surgery, is now common practice and considered very important for long-term outcomes. Often, this involves inserting an annuloplasty ring to reshape and support the dilated valve annulus.
Why do it at the same time?
It adds relatively little time or complexity to the overall procedure in experienced centers and is generally very well tolerated. This is a crucial strategy precisely because, as we said, reoperation just for repair or replacement of progressive TR years after initial surgery for left-sided valve disease carries a relatively high perioperative mortality risk. So, Addressing it up front with a combined approach is advantageous and often prevents the need for that higher-risk second surgery down the line.
Makes sense. Fix it while you're there.
Exactly. And similarly, performing mitral valve repair or replacement for moderate or severe secondary MR at the time of AVR for aortic stenosis can usually be undertaken with acceptable risk, again, aiming to address all significant issues at once when possible and safe.
And looking to the future, what about percutaneous interventions for these mixed valve scenarios? How are we seeing non-surgical approaches evolve in this really complex space?
Percutaneous interventions are an incredibly exciting and rapidly advancing area in multi-valve disease, yeah. It's important to note some limitations first. For instance, the presence of moderate or severe mitral regurgitation alongside rheumatic mitral stenosis is typically a contraindication to doing a percutaneous mitral balloon commissurotomy for the MS. The MR complicates things.
Okay, but what is possible?
Well, TVI, transcatheter aortic valve implantation, can be performed for mixed aortic stenosis and aortic regurgitation, provided the anatomical findings, the annulus size, coronary height, calcium distribution are favorable for secure device placement.
And combining procedures.
Even more significantly, the transcatheter management of both severe aortic stenosis and severe primary or secondary mitral regurgitation, often involving TVI plus an edge-to-edge clip repair like TEER for the mitral valve, has been undertaken with increasing frequency. This is happening in appropriately selected patients who are deemed to be at prohibitive or high surgical risk.
So fixing two valves without open heart surgery.
Exactly. These combined transcatheter procedures offer a groundbreaking, less invasive option for patients who might otherwise have had very limited or no treatment choices. We absolutely anticipate significant further advances in transcatheter treatments for multiple and mixed valve disease. It's truly revolutionizing how these complex cases are managed and expanding the options for patients who once had none.
We've covered a tremendous amount of ground today, really navigating the incredibly intricate landscape of multiple and mixed valvular heart disease. From defining the nuances of pulmonic regurgitation and stenosis, to dissecting that challenging pathophysiology of how these lesions interact and mask each other, and then outlining the comprehensive diagnostic and evolving treatment strategies, we've truly aimed to go deep.
Indeed. And hopefully you, the listener, now possess a more sophisticated and nuanced understanding of how these cardiac issues interweave, how they affect everything from a patient's subtle symptoms to the most complex diagnostic and treatment pathways. Moving you closer to that elite professional level of insight we talked about, the ability to see beyond the obvious, to really understand the interplay, that's what sets true experts apart in this field.
Absolutely. We've seen how one valve problem can cunningly hide another, how an arrhythmia like AF can suddenly destabilize a fragile system, and how that multidisciplinary heart team is absolutely crucial for making the best, most personalized decisions for these patients. So as we wrap up this deep dive, maybe consider this provocative thought. Considering the intricate interplay we've explored today, how might future advancements in personalized medicine and, say, artificial intelligence revolutionize that multidisciplinary heart team approach? Could they allow for even more precise, patient-specific strategies when facing these truly complex multi-valve challenges in the future?
That's a profound question indeed, and one that really highlights the ever-evolving, dynamic nature of cardiovascular medicine, doesn't it? And the promise of combining human expertise with these powerful cutting-edge technologies. Lots to think about.
Keep asking those questions, keep digging deeper, and we'll see you next time on The Deep Dive.